spectrum.
Thank you very much for the invitation to give an educational session on fetal akinesia deformation sequence, especially since I'm just a gynecologist within this audience of all geneticists. I coordinate the Expertise Center on Fetal Akinesia Deformation Sequence and Arthrogryposis Multiplex Congenita and work closely together with the geneticist. I have no declaration of interest. I built up the lecture first a bit of background, then how well or not well we do the prenatal detection, and then I hope there's plenty of time for discussion. FATS, I'll call it from now on, is a sequence, and the hypokinesia or akinesia will cause contractures in multiple areas, the flattening of the profile of the face, the webbing, the lung hypoplasia, etc., etc. And also there are associated anomalies, and especially in the brain and in the heart, but of course also in the extremities, besides the contracture. It's really a rare disease, 1 out of 13,000 newly borns. The prognosis is bad. The majority die perinatally. Since it fulfills the criteria of AMC, it is a form of AMC. Oh. Then I go a bit quick, but the first question I would like to pose to you, how many of you geneticists have been counseling parents of whom the fetus was suspected to have AMC or FATS? Please look at the QR code, and if you have it, I start the voting. So I'm lecturing to a very knowledgeable public, and I'm very pleased about that. Concerning the etiology, I'm rather short. Judith Melky will talk about the chromosomal anomalies, but you have to realize in AMC there is about 50% whole exome sequencing anomalies, and in FATS about 70%. And the rest is syndromal, external influences, or not known yet. But what they do share, all these various forms, probably, is that the motility is affected at least around the contracture. After birth, the classification has been made for AMC, and Judith Hall already started in 1989 with several publications, and the latest about the classification in 2019, that you can either classify according to the clinical symptoms, to the genetical findings, to the tissue involved, or the functional, whatever specialists need as a focus. For here, we do the focus on the clinical aspects, and then shortly said, group 1 is limbs only, group 2, limbs and possibly other body areas, and the group 3, also the central nervous system is involved. FATS falls below group 3, but there can also be maternal causes and infectious diseases, and the most frequent is the Zika. To give you a glimpse, but not really to read, is, I think, this nice paper of the French group of Letano et al., and Judith Hall was also involved, to give symptoms and possible underlying causes per group. And then group 1 is mainly the amyoplasia, and group 2 mainly the distal arthrogryposis, and group 3 either with central nervous system involvement or without, but several problems appear. And that's the group where FATS is settled. Before birth, we are hampered that we only have our ultrasound eyes. That's where we have to find our symptoms with. So I already explained that the etiology is varied, but another problem is the onset is varied. It can start at either the first, the second, or third trimester of pregnancy. And moreover, the expression is varied. So as a sonographer, you're very much dependent on which moment you look and how broad the phenotype already has been developed or not at all. Therefore, at least realize and be aware that the FATS spectrum is wide. And if I start at the first trimester of pregnancy, there can be no anomalies, but when there is a family with a history of FATS, it doesn't exclude that the FATS will develop later on. If you're confronted with, at 30 with contractures and a nuchal translucency, many factors can cause it, but one could also be a first start of FATS. At 13 weeks, seeing contractures and nothing else is often considered as being still physiological. But looking at the elegant paper of Bogers et al., who looked at three-dimensional contractures and posture of feet and hand, then you see that the physiological club feet is really between 9 and 10 weeks, with the latest at 12 weeks. So 13-week contractures should really make you aware of potential other problems. Going to the second trimester, at 20 weeks, seeing no anomalies in a family with FATS, you really have to know when the FATS started during the first pregnancy. And since it's often missed, that is not known. Once you do know when the FATS starts, within a family, the onset is mostly around the same period of time, with no more than 2 weeks difference. If you have a single contraction at 20 weeks and normal movements, I come back to that later, except in the contracted joint, you need to follow up 2 weeks later to see if it's stable or not. If at 20 weeks you see multiple contractions and normal movements except for the contracted joints, you also need to repeat it after 2 weeks to say, to have the hope that it's merely an AMC type 1 or 2 and not a FATS. Well, several items are presented here. It could also be that you see at 22 weeks contractures and a lack of gyration and abnormal movement. Also think about FATS. Contractions, flattening profile, think about FATS. Look also at the motility. If you see during 20 minutes in a fetus with contractures, no movements at all, think about FATS. But it can, as I already mentioned earlier, be during the third trimester of pregnancy that the mother tells you, I do experience less movements. There can be many, many underlying problems, and most often placental insufficiency. But if you excluded that by making CTGs, then also think about FATS and look at the fetus again, despite their normal 20-week ultrasound examination. Outcome from contractures from one area to multiple area are, of course, different. In one area, it's a not rare disease at all. And with recent results of whole genome sequencing, it's extra important to know the data when it's isolated club feet seen by ultrasound or with other anomalies. And I'll already mention it for the AMC and for the FATS. Prenatally, for us, it's very important to differentiate if it's AMC or if it's FATS. The prognosis of the child is very different. And depending on the legislation of the country, you have to have the suggestion of that diagnosis in the Netherlands before 24 weeks to enable a termination of pregnancy for the parents. But that's very different per country. Then the next question to you, audience, with all the experience. Do you know, oh gosh, yes, it's going all right, what the estimation is of prenatal diagnosis of AMC in infants, in a group infants with confirmed prenatal diagnosis? I hope you have the code scanned. Then I start the voting. I'm really very positively surprised because it's 50% what we know now. So you're very good. And I'll tell you about the study in which this was examined. It's the group of Dahan Oliel who examined this, and they found in 85% of the women who had the pregnancy that prenatally either a club feet or a clenched hand was seen, but only in 50% the suspicion of AMC was described by the clinical geneticist or the obstetrician. Over time, we do get better as obstetrician. This holds true for the club feet. First, a bit over 60%, but with increasing education, a higher level of prenatal diagnosis of club feet was found. And the same holds true for the AMC. 2007, there was a report of 26% prenatal detection, and it's getting better. In our expertise center, we added over more than 20 years now, systematic motor assessment, examined at least twice before 24 weeks gestation. And in those fetuses with more than 2 areas with abnormalities in the joint, we found 100% FATS. And then what is systematic motor assessment? You look during 15 minutes at which movements occur at the quality and the quantity. And we have age-related normal values. And to give you an example of the quality, there are 6 items we check. Is there a varied amplitude, speed? Do all body parts participate, but not non-stop together? Is the direction varied? Is the fetus capable of starting and reducing its activity during a burst of movements in which all body parts participate? And it should be performed fluent. And here you see a few healthy fetuses. Before we start the examination, we explain to parents that healthy fetuses are allowed up to 24 weeks to do nothing for 13 minutes. And if that's the case, we do not get nervous, but we have to double the observation time. This is an example of fetus with FATS, and five out of the 6 items are abnormal. And I can reassure you, here the most active part of the fetus, its general movements, is demonstrated. And the fluency remained, but the other 5 items were abnormal. I will give more examples later on. I hope you see the contrast with the healthy fetuses. In the period 2007-2016, we saw 66 fetuses with 2 or more contractions. And as I said already, we did structural and motor assessment with a 2-week interval at 20 and 22 weeks. And we have the follow-up of all children. And that way, we found the club feet, the AMC, and the FATS distribution as presented here. And I give you this information to go to the next slide, in which I inform you that all the fetuses with the club feet had normal motility, and they fulfilled the criteria because there was only limited participation of the contracted joint, the ankle. And the same held true for the AMC, only limited participation of the contracted joint. And in case of FATS, the quality was always abnormal. And this is in contrast to the differentiation into movement patterns here, and the quantity of movement patterns there. In about a third to half of the fetuses, that was still normal. And the 10 years prior to this period, we also had a cohort of FATS fetuses, and the same was found. Always an abnormal quality, in half abnormal differentiation, and in half the quantity. That means the term fetal akinesia deformation sequence is okay if you look at an old enough child, but before birth, the majority still moves. I want to stress the importance of the human phenotype ontology, and working together with a group of international experts, we found that the terminology in the HPO system is not sufficient for AMC, so we worked together to add those items we missed. And we just a few days ago got the message that we may send in, because we got a positive review. And so we may send in again. And the HPO also tries to stress to all workers in the field that we should know the change over time of the phenotype. And here I present a family who gave birth to 6 fetuses in a period of 10 years, and all fetuses developed FATS. But they also had a severe placental anomaly, the massive periphyllous fibrin deposition, within obstetrics well known as a rare placental disorder, always associated with reduced amniotic fluid. So they said, can this placental disorder explain everything? Well, we delved into the literature, found over nearly 2,000 manuscripts, but people like to lump data. So only in 633 manuscript we could find the individual reports of what was seen before birth and the actual outcome. And 14 congenital anomalies were found, of which 1 club feet and 1 flattening of the facial profile, mentioned in the article, a Potter sequence. So it's not very likely that the placental anomaly is sufficiently explaining the problems in this family, and also in all the reported families this has not been seen, and also not together with genetic anomalies. 2009 to 2019 also meant, for our hospital at least, a period before introduction of whole exome sequencing and during and expanding whole exome sequencing. And by now we know that 2 variants of unknown significance are found very near to each other. Parents are both heterozygous for both anomalies, and they luckily received 1 healthy child, not being a carrier of one of both anomalies. We got 1 reaction to this paper of a geneticist who thought it was probably the same problem, but comparing in detail MRI and post-mortem results, the FATS sequence was different in comparison to ours. But please react if you recognize this type of problem, because we would like to inform the family that more families have been demonstrated. I would like to emphasize the need of collaboration with the geneticist and with us obstetricians to repeat again and again how wide the spectrum is, and how well we have to be aware of this. And going back to motor activity, also there the spectrum is wide. And I want to educate gynecologists to learn this type of motor assessment. And I want to learn them how we experts look and how different it is from how, despite many years of experience, they look. So we compared experts with 11 years or more advanced ultrasound experience with those with similar experience, but also the same years of motor experience in fetuses with only clubfoot, AMC or FATS. And then you see that those with experience look at a way smaller area than do those without the motor experience. And we could compare the data and saw that motor experts really look at where in FATS the anomaly of motility starts, and that's either in the extremities or the trunk stops with moving. So they only have to look at a small part of the extremities and a small part of the trunk, and then they know it already. But they also look at the fluency. All fetuses should move fluent. Abrupt, you do only hiccuping and startling, in which arms and legs go together abruptly, and otherwise movements are fluent. But since FATS can also have problems in brain and in cortex of the brain, fluency can be alternated by abruptness, even by epilepsy episodes. All aspects those who have the experience will look at. Motor experts are trained, look at normal fetuses and those with single contractions, AMC and FATS, and do an inter-observer agreement before they do this work on their own. In the educational world, checking with eye tracking the difference between novices, intermediate trained people, and experts is very much a hype presently. And I like the explanation of the difference in chess players. Experts with the same number of chess pieces on the board as the novices were able to focus on less chess pieces because they knew ahead which were the possible next steps of the person you played with. So also with the FATs, you look where does it start, and the rest is of less interest. You can focus. Well, to make things difficult, even single contractions have a wide spectrum. They can disappear before birth, they can disappear after birth, the positional. It's an ordinary club foot, and it's followed up to 50 years of age. And with treatment, they have a very good prognosis, although they will not become an athlete. Those who remain persistent and are resistant against the regular Ponseti therapy, it comes back and it comes back. And together with our expertise center and the pediatric orthopedic surgeon, we check now in a population over the last 10 years and compare it with the prenatal findings, if we can tell parents more if there is a chance that the therapy will not directly be very positive and will need more frequent and longer therapy. Or it can persist and expand into AMC and FATs. Now I'll give you a few examples. A first one, referral for bilateral club feet. And here you see the child moving. It's really a clear club feed. And here you see the result of 4 of the 6 items demonstrated here. And everything was normal except the participation of the ankle. They were counseled by us, by the clinical geneticist. They had an amniocentesis. The results were normal. The follow-up revealed no anomalies. We performed the pediatric orthopedic surgeon counseling after the second ultrasound that we are more sure that's not an AMC or FATs. The delivery was uncomplicated, bilateral club feet confirmed and treated by the orthopedic surgeon. They are getting the counseling of the low recurrence risk and the advice of first and second trimester anomaly scan. The second referral consists of a fetus with multiple contractures, a normal NIPT QF PCR microarray and trio-West, and we could confirm endorotation of the shoulders, extension of the elbow, endorotation of the wrist, and atrophy of the arm muscles. And we did a motor accession. We had to inform the parents that the arm did not participate except limited movement in the shoulder, but no elbow or hand activity on both sides. The typical posture and the atrophy seen in the arms, both-sided, made us suspect for amyoplasia, so AMC group 1. In this fetus, the legs were not or not yet affected, and we advised motor assessment to be repeated in 2 weeks. And meanwhile, they got a consultation on the same day with the clinical geneticist and rehabilitation doctor. The parents opted for termination of pregnancy, and post-mortem, the fetus was examined and the diagnosis was confirmed. Counseling for future pregnancy was performed, and the low recurrence rate was told to the parents. Here we have a third example with referral for bilateral clubbed feet and at least one wrist. The other wrist could not be seen optimally. And the motor assessment at that 90-week moment demonstrated a slightly reduced differentiation into movement patterns, 5 out of the 6 quality aspects abnormal, but fluent moving fetus and normal number of general movements seen in the period. And at 19 weeks, the amniocentesis was performed. Then the parents requested another examination in 1 week because they couldn't make up their mind. And here you see the fetus moving. Again, you have to believe me, I show you the most active moment of this fetus, and you understand we at least need 15 minutes, and in these severe cases, we double the time that we really do not miss something. The differentiation was even normal this time, and the number of general movements also normal, and it moves still fluently, but amplitude and speed further reduced and slowed, and the participation further reduced, and no change in direction was possible, and there was no in and decreasing activity. Moreover, the contractions were extended. So now the parents were even more convinced that it probably consisted of the phenotype FATS, and after counseling again, they choose for termination of pregnancy, and thereafter the fetus was examined by the clinical geneticist and the pathologist, confirming the signs we had before birth. And 6 days after delivery, the trio results came and a de novo mutation was found. The counseling for the future pregnancy was performed, and the recurrence risk of this de novo mutation was estimated being 1%, permitting them to have invasive diagnostic during a next pregnancy, but also the option first to have ultrasound examinations and do it in case of anomalies. And the parents choose the latter in the next pregnancy, and the 2 weekly ultrasound examinations revealed a normal development. No invasive testing was done, and a term healthy child was born. Well, these are just a few examples. And this is one of the last slides already, because I want to have plenty of time for discussion. And how can you help us, obstetrician, to enhance prenatal diagnosis? Well, what is very helpful, that is uniformity in a multidisciplinary team. And if you are working in a larger hospital, you have many geneticists, and it's very pleasant for the parents if they have, during the first and the second counseling, the same advice. And if you, seeing the anomalies, ask us, did you do proper sonography in 3 directions of the brain? And was the sonographist specialized in heart examination, because that's a frequent occurring anomaly as well? And when have you planned the next ultrasound examination? help each other, because you can be very impressed by the first findings, but try to get it as optimal before you do the definite counseling over time. It's also helpful if geneticists counsel who do this more often, but still educate each other in the team. And the geneticists also educate us in the expertise center how they counsel. And knowing from each other how we counsel, also of the pediatric orthopedic surgeon, of the physiologist, makes that we prepare the parents better, how they are counseled. Keep up the follow-up examinations and register. And then the last 3 items I will give a bit more detail. As I already mentioned a few times, our geneticist tries, and I would say nearly 100% successful, to do the external examination together with the pathologist. Our pathologist appreciates to do it together to be even better prepared for the internal examination. And in our care pathway, we described the guideline for post-mortem examination. It's very much in line for the guideline for the post-mortem examination for children and adults, but since we look in such a earlier stage, in our advice is also included that all organs are evaluated as well as the placenta. In the same 10-year cohort, from the 14 post-mortem examinations, 12 revealed additional findings, additional to the ultrasound findings. In our hospital, we made a care pathway from the moment of the referral, time point 1, to after about 10 weeks after the delivery, the final counseling, and the steps in between, so that and the specialists and the parents know when they can expect a next examination or counseling. And I would ask to the audience later on if they also have such care pathways in their hospital. Since during the waiting time of all these examinations, patients feel anxious, I'm curious if you are aware of the patient support group existence in your country. And I would like to know if you are aware of it in your own country. We inform our patients that the patient support group is there, and it's up to the patient if they contact them for peer support. You are such an amazing, good audience. I'm really proud. For those who are interested, I not only have here the countries mentioned, but also the websites. And I know that Australia and New Zealand also has a patient support group, but they were even mentioned in our overall European support group, but their websites were old, so I didn't include them. I'm sorry. Working together is not only important with the patient support group for the peer support for the parents, but also to do education and research. Robert Boekenstein, I need this one, is the chair of the Dutch Club Food Society, and he used the COVID period to organize it within Europe. And he was so good, he is now the international chair of club food societies. They have an enormous population of people with club food, which makes them very strong in advices to us doctors. Then we have Remco Jansen, who is the chair of the Dutch patient AMC subgroup of our muscle disease organization. And we have very active Victoria Sanchez from the Spanish patient support group with her son, visiting us last year because Jill John defended her thesis and we had a congress, including Isabel, with all the people from our expertise center. And the patient support group checked our care pathway and give their additional advices, and we do surveys together with their help. So it's really, it keeps you modest what the questions are, and we have loads of work to do it better in the future. If you're interested to learn more about AMC, come to Montreal in September, October. It's only live, I'm sorry. And it's open to question and discussion now.
Thank you so much, Johanna. This was very, very brilliant insight from very basic to what we have to do moving forward. The floor is open for questions. Please come to the mic if you have any. While we wait, I would like to ask one question. When you see the first signs of FADS and genetic testing is prescribed, but it comes out negative for known genes, what's the workflow to counsel the parents for subsequent pregnancy? And do you reanalyze until you find something that could be responsible for the cause of the previous pregnancy?
I must say you're a bit difficult to understand, but if I understand it well, when you offer genetics, do I realize that?
So if the first test is negative for already known genes,
yes,
you do not know what has caused the FADS, and the parents decide to terminate the pregnancy, how do you counsel them for the subsequent pregnancy? And how do you reanalyze until you realize, okay, we have found the cause now?
I really like that question. Now I understand it. Our geneticists always say if we do not find anything and we get a live child after birth, we repeat it if we have the material. Because they try to explain me again and again that after birth they can do more than before birth. For an obstetrician it's a bit difficult, but there seem to be more possibilities to go in more detail. And further on, all patients who are seen in our expertise center are informed what we know now can change if we become better. And we will ask you if you are allowed to repeat, and we do DNA storage. And then another thing, the whole genome sequencing is not done yet. But we keep the material, and if we are with a larger population, and we tried a year ago to get with an international group money to do, then we really would have a larger population. But we didn't get the grant. It was 10% possibility, but we will continue to do so. But the parents know it's not the final situation. And before they start counseling, we know 50% gets the diagnosis. So the rest we do purely the advice on our sonographic examination. And then the motility helps to realize the parents that we can tell FADS because of the contraction, but if they see the movements and see the change over time, we do not have to say anything. The parents recognize it. It's so impressive.
We have another question from the audience.
I was curious about if there is in the diagnosis of the FADS patients in your cohort, have you seen a lot of cases of congenital myasthenic syndromes that can present like FADS on a more severe phenotype?
I like that question very much as well. You saw on the first slide that we are an expertise on AMC and FADS, and getting the acknowledgement by our health ministry and the patient support group. Our part on a woman with myasthenia gravis was thrown out because they did not find it important, and they've found it overwhelming for the woman. But we just continue to see all women pregnant with myasthenia gravis and do a 20 and 22-week motor assessment to find those rare cases in which FADS develops. Because we have seen it, and probably in the next 5 years we will not see it, but the mothers get the proper prenatal evaluation they earn.
Okay.
Yeah, go ahead.
Hi, Erica Fernandez from the U.S. I work at Nemours Children's Hospital, and we have a multi-specialty AMC clinic that I work with there. My question was, is fetal MRI used in any instances, and has that been shown to better characterize the contractures or lung volumes?
To use fetal MRI, especially to exclude brain anomalies, I think per center you have to decide to do so. Personally, I'm very interested comparing neurosonography in 3 planes ultrasound with MRI, and we had Van der Knoop doing a thesis on this subject, and we found in acquired brain anomalies that the 3-plane ultrasound was as good as the MRI. Now we are a huge ventriculomegaly, you can see by ultrasound, but see it Zellweger with microgyration, you really have to know your neurosonography to see it. So if you feel more familiar with the MRI because you do not have those neurosonographers, do an MRI, the other way around. So we don't do it because we have the expertise.
Thank you.
Okay, let's thank the presenter again. And the next talk will be by Professor Judith Melchier from Université Paris-Saclay. And her talk will be about genomics of arthrogryposis multiplex congenital. We are looking forward to your